Good midday. It's not morning, it's not afternoon. Hi, I'm Miriam Alexander. I'm the director of the Mid-Atlantic Public Health Training Center, and we're the ones who sponsor these monthly training grand rounds. Just for everyone's information, we are live online, and we usually have several hundred people watching from local and state health departments around. So you'll see at the end that they'll all be participating in questions, and welcome to everybody who is with us for the webcast. Today's Grand Rounds is entitled, It Takes a Village, Promising Strategies to Reduce Infant Mortality in Baltimore City. Before we begin, I'd like to tell you about some of our center's ongoing activities and the ones coming up very shortly. Dr. Carolyn Fowler is going to be teaching both in Delaware and Washington, D.C., a session called Achieving Outcomes Through Best Process Design and Implementation. Dr. Kay Edwards will be teaching a session called Managing Stress and Staying Positive in Today's World. And we also have a session coming up very shortly called Getting Your Work Published in Academic Journals. That is tomorrow in Washington. For those of you watching online, I invite you to submit any of your questions to the email address here, maphtc@jhsph.edu, and I will be monitoring that email account during our presentations. If you are watching this webcast in a group, please send us an email and let us know how many of you are watching so that we can keep track of all those folks who are with us today. There are sign-in sheets available on the website, so those of you online, please do take advantage of those and fax it back to us at 443-287-7075. And with housekeeping over, I'd like to begin our session. Today's session, as all of our sessions, will address a very important public health topic, and we will have both someone who is grassroots doing local public health, and then one of our esteemed faculty members talking about that work and putting the whole local work in context. Rebecca Dineen will start, and she is the Bureau Chief for Maternal and Infant Care in the Baltimore City Health Department. She received her Master's of Science in Health Policy from the other School of Public Health, up the road 500 miles. Oh yeah, the one in Boston. In June of 1998, she has supported and led the reproductive health and maternal and child health public health programs for more than 15 years in the areas of strategic planning, proposal development, project design, project implementation. She's worked internationally and domestically. She was a Peace Corps volunteer in Central Africa, and she has worked with Dr. Sharfstein, who was our former Commissioner of Health here in Baltimore, woof, I've got it on my mind, to develop the strategy she's going to speak about. She will be followed by Dr. Donna Strobino, and I'll introduce Donna after Rebecca finishes. Thank you.
Thanks very much. This is a great turnout, and I see some familiar faces in the audience who are probably far more capable than I am to be giving this presentation. So I am so excited to be here, and it's really an honor to be talking with Dr. Strobino, who's really helped us a lot in shaping the strategy, and actually Dr. Bernie Geyer, who's back there, who's also helped us a lot with working on the strategy to improve birth outcomes in Baltimore City. And I also want to say that I've lived in Baltimore for 10 years, but I only started working in Baltimore in September. And I live in outer Govans. And as I started to sort of look at Baltimore City, I realized that so much of what we're seeing in health disparities and the problems that we deal with in infant mortality are very similar to what work we are doing in the developing world. And it's just, it gives me a lot of pleasure and a lot of intention in my work to be in Baltimore working and living and trying to improve the city's birth outcomes. And African Americans in Baltimore are dying at an alarming rate, as we know, with little progress that's been made over the last decade. The strategy to improve birth outcomes in Baltimore City, which we're calling SIBO, sets out a 3-year citywide vision for improving the critical problem of poor birth outcomes. The strategy was launched by the mayor of Baltimore City in April 2009, and it's going to begin to be implemented in communities in October of 2009. And it's a multidisciplinary, multi-level strategy led by the health department under the mayor's cabinet. It's important to note that the approaches and services that are being put in place are really based on the past 2 decades of work that have provided a platform in which a renewed focus and comprehensive strategy for improved birth outcomes can be launched. So the questions that guided the strategy is, how big a problem is infant mortality in Baltimore City? What do we know about improving birth outcomes? What strategies can be adopted to address this problem? And which partners are currently involved and needed? And then finally, what are our next steps? As we all are aware, infant mortality is a critical indicator of the health of a population. It reflects the overall state of maternal health, as well as the quality and accessibility of primary health care available to pregnant women and infants. And in Baltimore, infant mortality is a public health crisis. That's what the mayor called it in her press release in April of this year. In 2007, 625 babies died in Maryland, and of these, 112 died in Baltimore City. And that number increased in 2008 to 118 infants, and nearly all of these babies were African American. So this slide shows the rate of infant mortality across the state of Maryland, Baltimore County, Baltimore City, and Prince George's County from 2003 to 2007. And Maryland is represented by the pink line, Baltimore County by the light blue line, Prince George's County by the yellow line, and Baltimore City by the dark blue line. From the graph, you can see that Baltimore City and Prince George's County, which are the top two lines, as I said, let's see if I can, there, are the major contributors to Maryland's poor infant mortality rates. The rate of infant death in Baltimore City in 2007 was approximately 11.3 deaths per 1,000 live births, and for African Americans, the rate was 15.5 per 1,000 live births. By comparison, Maryland's rate of infant mortality is about 8 per 1,000 live births, and Baltimore County is 7.6. And as you can see from this slide, there's been relatively little movement in these numbers over the 5-year period, with the exception of Prince George's County, which has now exceeded Baltimore's rates. So this map shows the excess number of infant deaths that we're getting into Baltimore City now, excess number of infant deaths by census tract in Baltimore City. And while it's not that easy to read on this map, this depicts where infant deaths are clustered in Baltimore City neighborhoods. So the darkest areas of the map are the census tracts in which there are 4 or more excess infant deaths. And when we use the term excess infant death, we mean the number of infant deaths occurring in a particular census tract over the years, we use the years 2002 to 2006, that are in excess of what we would expect if the infant mortality rate in that census tract was the same as the rate of that for Maryland for the same time period. So the birth outcomes strategy identifies 12 of the city's 55 neighborhoods for initial targeting. And from 2002 to 2006, these neighborhoods had approximately 60% of the city's total number of excess infant deaths and only 27% of the Baltimore births. So just a quarter of the births and more than half the deaths. The strategy proposes that a targeted community-based program in each of those neighborhoods will take responsibility for the birth outcomes of the entire community. So this map, the leading cause for infant mortality in Baltimore tell an important story. Let's first look at the United States, where the overall leading cause of infant mortality is congenital abnormalities, followed by low birth weight, preterm birth, and then sudden infant death syndrome. In Baltimore City, low birth weight and preterm birth and sudden infant death syndrome make up the 2 leading causes of infant death, underscoring how many needless deaths there are in the city and that how many deaths could potentially be preventable. If we drill down a little bit into the leading causes of infant death in terms of preterm birth and low birth weight, we can see that in Baltimore City, and trace back over the past decade, we can see that there's been relatively little movement in these numbers as well. The 2 dotted line trend lines on this graph represent the percent of preterm birth in Baltimore compared to Maryland from 1997 to 2007. And the 2 solid lines represent the percent of low birth weight births in Baltimore compared to Maryland. And since 1997, there's been little to no progress in reducing low birth weight or preterm birth in Maryland and in Baltimore, with a greater percentage of preterm birth and low birth weight in Baltimore. And in 2008, maybe you all know that the March of Dimes issued a state-by-state scorecard on premature birth, and Maryland scored an F and ranked 35th of the 52 states. And the strategy developed by the Baltimore City partners is really a call to action that we must do and can do better than this in the future. So this graph just shows the trend in unexpected infant deaths that occurred during sleep, and it's a number. Baltimore City's Child Fatality Review identified 132 infant deaths that occurred from 2002 to 2008, and this graph shows the number of deaths due to unsafe sleep practices in Baltimore City over this time period. And while it looked like there was a promising dip in 2005, the numbers of unexpected infant deaths during sleep is largely unchanged over the past 7 years and is a large focus of the work that we do in Baltimore City. And in fact, Dr. Stephanie Reginald is with us right now, and she's really in charge of our Safe Sleep campaign. So after examining these data, the partners developing the strategy looked at the factors that contribute to preterm birth, low birth weight, and unsafe sleep, and noted that they can be bucketed or summed into 3 basic categories, including the health of the mother and father before conception, medical and social support during pregnancy, and access to critical knowledge and services after birth. Dr. Geyer, who's back there from the Johns Hopkins School of Public Health, helped us look at these factors in a little more depth. And this slide summarizes in more detail what guided our recommended strategies. The columns represent the life stages related to pregnancy, pre-pregnancy, pregnancy, and post-pregnancy. And then the first row shows what kind of care might be offered in each of these stages: preconception care, prenatal and obstetric care in pregnancy, and postpartum and neonatal care post-pregnancy. The second row is the one that we're most concerned with, that shows the modifiable factors related to poor birth outcomes, such as smoking, substance abuse, poor nutrition, domestic violence, and so forth. The next row identifies what are the underlying and very critical factors as well, that are determinants of poor reproductive health, such as poverty, environmental exposure, poor housing, and racism. And then finally, the last row shows the interventions that could be implemented in each stage that would address the modifiable factors, such as planning pregnancies, good nutrition, safe sleep practices, and education. The strategy itself is really focused on the modifiable determinants, but there's a call to action across the city, which is why it's in the mayor's cabinet, that the housing department and the parks and recreation group and all of the other areas of the Baltimore City major agencies be involved to look at birth outcomes as well, so that this is a multidisciplinary strategy. So this is all to say that there's no quick fix solution. We know that there's research that I know that Dr. Strobino is going to get into a lot more detail that does indicate that certain high impact service areas, if implemented comprehensively and cohesively, can improve birth outcomes. Of critical importance, I want to underscore, and what we certainly say at the health department, is the primary healthcare system, the critical role that the primary healthcare system can play in sort of being a central and organizing role. There was a RAND working paper on ambulatory care, sensitive hospitalizations, and emergency department visits, which is quite a mouthful, in Baltimore City, and it underscored how many Baltimore residents use emergency rooms for primary care. Baltimore needs the medical home model to help manage chronic health conditions and offer multiple opportunities for screening and referral to mental health, substance abuse, smoking cessation, and domestic violence services. So based on the framework that I talked about earlier, we selected the strategy that we put together, identifies 11 high-impact areas that we believe, addressed in combination, will have an impact on the poor birth outcomes in Baltimore City. And they include primary health care in a medical home, obstetric care, home visiting, drug and alcohol treatment, domestic violence interventions, mental health care, smoking cessation, family planning, nutrition support, breastfeeding promotion, and safe sleep education. And while we realize that's a lot, and we're still working through what are the dosages that would be needed in each of these interventions, we feel that these are comprehensively the high impact areas that will have the greatest difference, or that can make the greatest difference. So we did a short gap analysis that's going to continue through the rest of this planning period up until October as part of developing this plan. And we reviewed the current services offered in Baltimore and concluded that they're really funded inadequately and are very fragmented. Some of the key gaps include a poor coordination of service even within the health department itself. And as we're getting into a tighter and tighter funding environment, the problem of poor coordination of services is really becoming critical. There's also just the lack of adequate primary health care that I referred to earlier. The lack of health insurance leading to late prenatal care. So the complexity, I work with home visitors, and just listening to the moms who we home visit talk about getting enrolled into an MCO is really daunting. It takes a PhD to understand the insurance system. And what happens is a woman often is in her second or third trimester before she's actually getting into prenatal care. Other gaps include noting a lack of minimum standard of care for young women and men in the city. And that is, for example, some adolescent care providers might offer reproductive health care, substance abuse assessment, and referral and comprehensive medical care. Others might just fill out a school physical. And finally, while there are community outreach and home visiting programs that are targeting poor birth outcomes in the city, and there are in fact 8 of them in the city, The programs cover a very small proportion of the population or aren't population focused. They're focused on the clients that they serve, but not necessarily on the neighborhoods in which they're existing. And the limited individual and community attention to promoting healthy behaviors versus service delivery is really a critical component, we think, of these poor birth outcomes. Most of these outcomes we think are preventable with greater utilization of existing services and better and healthier behaviors before, during, and after pregnancy. So there are this strategy has three primary outcomes measures that relate to the most common preventable causes of infant death in Baltimore City. And the goals are to achieve in a 3-year period, and this is a cumulative target, a 10% decline in preterm births, representing 283 preterm babies, a 10% decline in low birth weight, representing 259 low birth babies, and a 30% decline in deaths from unsafe sleep, representing 12 fewer sleep-related tragedies. Now, we know that, in fact, these are incredibly ambitious goals and that we really need a 30-year vision. The point of having a 3-year vision is just to create the urgency that was created, I think, back in 2005, which is maybe one of the reasons that we were seeing such good numbers, but an urgency around this issue that's across the city. The success of the community programs also are going to be looked at in terms of linking residents to high-impact services. And that's going to be closely tracked. So we don't want community programs to be offering services just by themselves, but to link into the services that exist in the city. So the comprehensiveness of the strategy and its critical components are illustrated in this figure. The strategy is framed on the left side by an improved enabling environment, which is defined as a policy and practice environment that allows for successful implementation of the plan. So an example might be, if you are working in a city agency, what are the maternity and paternity policies? Is it a breastfeeding friendly environment? So the policies and practices in the places we work and in the city itself, are they conducive to making this plan really be successful? The strategy is framed on the right side by improved partner collaboration. A lot of folks are working in silos, including the health department, and we really need to reach across agencies and organizations. At the base of the frame is the essential role of monitoring and evaluation. Within the frame, you can see the tripartite approach, or a 3-pronged strategy that includes increasing demand and utilization for the high-impact service areas, expanding capacity of these services to meet demand, and improving service quality. These approaches point to the outer circle that shows citywide efforts aimed at all community members, agencies, and health providers. Then you see in the first inner circle the community programs that I referred to in very high-risk communities. And finally, Baltimore citizens in each phase of the life cycle are shown at the core and the innermost circle of the strategy, illustrating the central significance of individuals in the community. The 11 high-impact service areas are directed toward and thus support individual health and healthy behavior. So I'm just going to walk through briefly each of the prongs, or each of the 3 strategies. The first one is increasing demand and utilization of services. And what we're planning on doing is a citywide education and communications campaign that's going to disseminate key messages to inspire city residents to find a medical home, seek drug treatment when needed, quit smoking, and engage in the other high-impact service areas. The campaign will permit participation and reinforcement by agency staff, health providers, hospitals, and other organizations. And then the strategy and related materials in the communications campaign will be available through a web-based portal that has public access. The communications campaign we've issued a request for qualifications, and we've gotten a bunch of applicants in, and we're deciding on which vendor will be selected. But the idea is that this is not just a campaign, a media campaign, or a social marketing campaign, but that it's really oriented around behavior change in communities. Then the second part of this increasing demand and utilization is our community-based programs in the high-risk areas that will generate demand for each of the 11 high-impact service areas through intensive outreach, education, and referral. So drilling into what we're hoping that community program might look like, they're going to be modeled on a support continuum for birth outcomes, as shown in this slide, and it models after, I don't know how familiar you all are with the maternal child health pyramid, but it's sort of derived from that. And the pyramid depicts the core interventions that will be offered by each of the community programs. So interventions will aim to engage persons between the ages of 11 to 49 in each neighborhood prior to, during, and between pregnancies. More intensive services will be offered during pregnancy and through the infant's first year, depending on need. And at the top of the continuum, professional and/or community-based case management will be offered to the highest risk women in the pregnancy and postpartum periods. So those would be women who are victims of domestic violence, women with poor birth outcomes in a previous pregnancy, women with HIV/AIDS or syphilis, and women with chronic hypertension or diabetes. Then at the next level of the continuum, programs would offer paraprofessional case management. So at a minimum, we would like all women in the targeted geographic areas to receive one home visit upon discharge from the hospital following delivery. And in some cases, that might be the only home visit that's offered. And the reason I'm getting into this level of detail is just to say that there are a lot of women that we're not seeing at all in prenatal care. And a lot of the way the home visiting programs find women is through prenatal care. So if we have a universal postpartum visit in the targeted geographic areas, we at least can find these women after they've delivered and then be able to follow them up. On the third level of the continuum, programs will offer targeted outreach, health education, and support services such as transportation. But by far the largest role of the community programs will be mobilization, advocacy, and resource development and referrals as represented on the fourth level of the continuum. The way that this sort of looks like right now in the city in terms of resource allocation is the inverse of this pyramid. So that a lot of resources are being spent on home visiting and maybe not so much on the public health intervention side. And that's sort of the big difference with maybe the way the services are being delivered currently. The second prong and the second part of the strategy is increasing capacity. So this is to increase capacity for the 11 high-impact service areas. So for increasing demand and utilization for services, we need to be sure that there's adequate service capacity to actually meet this demand. And there are several agencies that are called to action through this strategy. They're Baltimore Healthcare Access, the Family League of Baltimore, Baltimore Substance Abuse Systems, Baltimore City Health Department, Baltimore Mental Health Systems, Baltimore Healthy Start. And they're being called to assess deficiencies that might exist in the high-impact service areas. Is there enough obstetric care given to the women who are at high risk? What is the drug and alcohol treatment situation for women? What's the prevalence of drug and alcohol problems within pregnant women in the city? Mental health treatment for women and men by city agencies. And the role of men is not coming across so strongly maybe in this presentation, but is a major part of the strategy. And agencies will be expected, after they've assessed the deficiency, to develop and implement a plan to address the deficiencies and directly link efforts with these community-based programs. Then the third part of the strategy involves improving quality of high-impact services. So it's not enough to have lots of demand for services and plenty of access without ensuring that services are standardized and culturally competent. So particular focus will be on health services for adolescents and young adults, as I referred to earlier, services specific to women, and services for the mother and infant. So as an example, the health department will work with experts in adolescent health care in Baltimore to convene a summit, including pediatricians, adolescent physicians, family practitioners, and nurse practitioners, to establish a quality standard for all young people in the city. This will be summarized into a checklist that will cover each young person every year and be consistent with the Medicaid requirements for care. So these just outline a few of the partners that need to be involved in improving birth outcomes for Baltimore City. This has to be a coordinated effort among public and private institutions, from our health providers to our business leaders, from the Department of Social Services to our school teachers. Messages related to preconception health, early prenatal care, safe sleep habits, and so forth must be consistent across our institutions and should come from multiple disciplines. We also must rally together to find the highest risk women in Baltimore City who are still falling between the cracks. Many of the deaths discussed in the Fetal and Infant Mortality Review Board often involve people who've had little or no prenatal care. And Dr. Reginald and I have recently gone to the Women's Detention Center, that is a 45-day detention center for women who have committed some kind of crime related to drug or alcohol. And we ask the question always, how many of you know somebody or have had an experience with a sleep-related death? And we find that over half these women are raising their hands. These are women who are also not receiving prenatal care and who clearly could be great conduits of information for us. So it's finding those women that seems to be very tricky in Baltimore. Once they get into the system, we can find them, but those that are not in the system, we're trying to figure out how we can reach them. Finally, all partners must start addressing how to ensure the issue of payment of services. I recently was talking to a home visitor, very passionate home visitor, who said he had a very high-risk pregnant woman who wanted to participate in a birthing class and was turned down by 2 hospitals because her managed care organization wouldn't pay for the birthing classes. And it's just really important that we start to think through how can we get these services to folks that really need them so that we can improve birth outcomes in the city. So for the next steps, the mayor's office or the mayor's cabinet will, the mayor, in fact, will be convening a steering committee. That should happen in the next month or so. As I said, we're working, the Baltimore City Health Department is working very closely with the Family League of Baltimore City, and we've just issued 2 requests for qualifications, one for an evaluation vendor for this plan and one for a communications vendor. We've gotten about 16 applications back through our system, and we're looking at assessing which vendor will be appropriate. With those vendors in place, we'll develop and oversee a logic framework and a detailed implementation plan. This is really just the sketch and, like I said, a citywide vision, but there's a lot more detail that needs to be fleshed out here, as you can imagine, and we're working a lot with Dr. Strobino as well to work out what those details really will be. We're starting to engage city agencies in assessing capacity and quality of services, and in October of 2009, there'll be a request for proposals issued to community programs, and we're expecting to have several community programs starting in this first year. So I really appreciate your time, and I will pass the baton to Dr. Strobino.
We'll take questions after both of our presenters have spoken. And again, for all of you who are with us through the web, the address that you can send your email questions is maphtc@jhsph.edu. Our next speaker is very well known and loved by many of us, Donna Strobino. Donna has been on faculty and as a student here at the school for many years, and is really very well versed in the subject matter and really in the health of infants here in Baltimore. She has her PhD here from our school when we were still in the Department of Population Dynamics. She's the director of the Maternal and Child Health Leadership Training Program, which is a core training program in our Department of Population and Family Health. Much of her research has centered on the reasons why disadvantaged women have unfavorable pregnancy outcomes and evaluating interventions to improve their outcomes, including teenagers, low-income women, African American women, and women who are substance abusers. She's been involved in evaluations of a number of perinatal health programs in several states in the U.S. as well as here in Maryland. With that, I'd like to welcome Donna.
Thanks, Miriam, and thanks to Rebecca for an excellent overview on the Baltimore City strategy. I actually want to take the opportunity today to really talk about how do we look at such a strategy from an academic perspective. And part of this work that I'm actually going to be talking about originated many years ago when the first President Bush actually announced the initiative for Healthy Start with the goal of reducing infant mortality by 50% in the communities in which Healthy Start was to be implemented. And at that time, I was working with Bernie Geyer, Pat Ocampo, David Page, who's here, Marianne Oberdorf, who was a student in the department at that time. And it was very clear to us that even with intensive resources put into the communities in which Healthy Start was going to be initiated, that it was very unlikely, given what we knew from a scientific perspective, that there would actually be a reduction of infant mortality in those communities by 50%. So we decided that at that time to actually go about estimating what the potential impact could be of various strategies that we knew about and for which there was evidence in the literature that at that time that those strategies could improve infant mortality. And so what I want to do is describe the strategic framework for reducing infant mortality rates. And this strategic framework really was the brainchild of Bernie. It's a very straightforward, very clear framework, and it actually works very well in at that time, looking at the known strategies, but also looking at the 11 high impact areas that are being addressed by the Baltimore City Health Department currently. And one of the things that was of interest to me, and I remember talking to Bernie about this early on in the spring, about the initiative in Baltimore City, was that in fact, would be a good opportunity to actually try to update those estimates that we had done on looking at infant mortality reduction. And this was done back in the mid-1990s. It was actually published in 1995, so it was actually in the early 90s. So what I'm going to do today is really describe the strategic framework. And then I'm going to talk about really the evidence-based for that strategic framework, primarily presenting what we knew at the time when we first estimated what might happen to infant mortality. But I'm also going to talk a little bit about some of the newer approaches that have been implemented. I'm going to actually present those earlier estimates to show you what our estimation was at that time in the early 1990s. On what kind of impact there might be of the known strategies. And Ken Schoendorf, who was at NCHS at that time, was very helpful in providing the data for us. And then I'm actually going to discuss accessing some of the data for updated estimates, particularly related to the 11 high-impact service areas that Rebecca referred to. And Meredith Matoni, who's sitting in the front row, is an MHS student in our department who's been working with me this summer and actually looking at some of the literature on what we know currently about some of those high-impact areas. So what I want you to think about when I'm talking about the strategic framework is really this conceptual timeline. And you might think it's interesting because it's in fact the same conceptual timeline that Rebecca showed you when she organized the services in the high impact areas. And basically we're talking about the time prior to conception, which then affects a woman's health when she becomes pregnant, looking at then low birth weight, neonatal mortality, so mortality in the first month of life, and then infant mortality, mortality in the first year of life. And basically, if we think about infant mortality really is a function of two things, or two pieces of data. And one is the distribution of risk factors in a population, and then the risk-specific mortality rates in a population. And all of this is population-based, and it's a population perspective. And I think that's what's particularly, to me, encouraging about the Baltimore initiative currently, is that it is population-based. It's not program-based. And that is a focus that I think is somewhat relatively new to the city, in the sense that there's an attempt to actually marshal all of the resources in a given area to bring about changes or reductions in infant mortality. The other aspect of the strategic framework that's relevant here, and Rebecca has already shown you data on this, is that birth weight and preterm birth are the strongest predictors of infant mortality, and that improvements are likely to result in reductions in infant mortality, are likely to result from reductions in low birth weight or preterm birth. But there are also some causes of infant mortality which will not be reduced by interventions that focus on low birth weight and preterm births alone. And that's sort of the background for the strategic framework. And basically, in this strategic framework, there are 4 strategies for reducing infant mortality. The first is reducing the proportion of high-risk pregnancies. The second is reducing the incidence of low birth weight or preterm births by improving health care and health behaviors of women. Thirdly, to improve birth weight-specific survival, and that's primarily by strengthening obstetrics and neonatal health systems, and then by reducing deaths from specific causes during the neonatal period, such as sudden infant death syndrome. This was a framework that we used back in the early 1990s, and you'll see that it's still very apropos to the strategies that are currently being implemented in Baltimore City. So if we look at the very first strategies to prevent high-risk pregnancies in a population, 2 major strategies: family planning, preconception care. At the time we did the initial estimates, really most of the research and the literature that was available really focused on family planning strategies and less so on preconception care. Preconception care was a concept that was being discussed. It was particularly being discussed among nurse midwives, but it wasn't a concept for which we had data or information at that point. So if we looked at the family planning strategies, the strategies that we were particularly interested in were really reducing the incidence of high-risk pregnancies, and that had to do with reducing unwanted unwanted births, especially in older women, reducing closely spaced births, and also then reducing births to teenage mothers. And those were factors that were important in the United States at that time. And there was evidence suggesting, particularly after introduction of oral contraceptives, that there was a reduction, particularly in closely spaced births and unwanted births among older women following introduction of the oral contraceptive back in the late 60s and the early 70s. And I might add, I am actually going to show you some estimates subsequently, and those estimates really were based on projecting what kind of change we might see, for example, a reduction in unwanted births, multiplying that change times what the estimated rate was of births for that particular category or for that particular factor, so for unwanted births, and then determining how many births actually or deaths might be reduced, or in this particular instance, how many high-risk pregnancies might be reduced by implementing those particular strategies. And so it's really sort of the idea of knowing the odds ratio and the proportion in the population and getting an estimate of population attributable risk. I'm not going to show you how we did that or anything. I'm just going to show you actually the results of that those estimates shortly. We're thinking of preconception care. We're primarily thinking about preconception counseling. In the context of the Baltimore City strategy, we're talking about primary care and the health status of women prior to becoming pregnancy as well. But the factors that you're interested in preconception care, and this is not something that we estimated before, but it's something that we're interested in at least trying to estimate currently, and that is reducing risk factors that women present with before pregnancy so that they do not present then with those problems in pregnancy. There's a lot of evidence to suggest that preconception care is effective for women with diabetes, and in particular, reducing birth defects for women with diabetes who are in good glycemic control when they start pregnancy and stay in good glycemic control throughout pregnancy. And then also, behavioral interventions are possible at this time, particularly reducing smoking, interventions that have to do with taking folic acid, interventions that have to do with reducing substance abuse. So some of the strategies to prevent low birth weight and preterm birth that we looked at in the population were routine prenatal care, comprehensive prenatal care. We also looked at some of the preterm birth prevention programs that were quite popular at the time. I'm not going to talk about those because basically there's not a lot of evidence to suggest that those programs actually are very effective, particularly among low-income women. We also looked at nutritional intervention with particular focus on WIC, and then also health promotion that had to do with changes in health behaviors during pregnancy. If we actually look at routine prenatal care, its historical influence is really important, and basically in 1985 there was a publication that was disseminated widely called Prevention of Low Birth Weight. And really, that publication promoted prenatal care, routine prenatal care, as the panacea for reducing low birth weight. And many of us at that time were skeptical about that because, in fact, the evidence to suggest that routine prenatal care alone would prevent low birth weight was pretty limited. Basically, prenatal care was initially introduced to focus on identification and pregnancy identification and prevention of pregnancy complications. And basically, the idea at that point was really focused on improving health for the baby, although it also had the impact of improving health for moms at the time as well. Now, there's mixed results on routine prenatal care, and basically there are a lot of population studies that show women who get early prenatal care actually have better pregnancy outcomes. But when we actually look at time trends and changes over time, increases in utilization of prenatal care, we see no effect on low birth weight rates. And one of the reasons we see them in the population studies that primarily look at women who get early prenatal care is because that's a self-selected group. They tend to be somewhat the women who are sick or have potential complications, but they're more likely to be what we call sort of the worried well, and that in fact they are the ones or the women who actually have better outcomes. And so we have a real self-selection effect going on there. So we don't have a lot of documentation that routine prenatal care itself actually is very effective, so we never actually included those in our estimates. We did look at comprehensive prenatal care, though. And what comprehensive prenatal care does is it includes all of those, the medical, clinical pieces, but it also includes a lot of the things that Rebecca was talking about, social, psychosocial services, nutrition services, health education, health promotion, high-risk referral when necessary. And it really emphasizes the problems that are particularly common for low-income women. And there's evidence that, in fact, comprehensive prenatal care improved outcomes for adolescents from quasi-experimental designs. There were several quasi-experimental designs that actually show on a population basis that implementing these programs when compared to areas where these programs weren't implemented improved low birth weight rates. There have been a couple of clinical trials that have been relatively small, less encouraging in terms of their outcomes. And most of these studies actually have looked at low birth weight. But when we were doing our estimates in terms of trying to determine what would happen for infant mortality from prenatal care, we actually used the estimates from the quasi-experimental studies. The clinical trials were not available at the time. Health promotion. Health promotion often focuses on smoking education or smoking reduction and substance abuse programs. Now, counseling about smoking and substance abuse programs have generally been routine components of public programs, but there are more intensive programs that have been implemented. There also has been an attempt to coordinate services for women who abuse substances and to provide substance abuse treatment to them by referral. If we actually look at the data that are available, there are actually modest improvements that have been shown in birth weight associated with smoking cessation programs. One of the issues when you look at the smoking cessation programs is that, in fact, interestingly, a lot of women stop smoking early in pregnancy. That's not as true, I think, among some low-income, high-risk women, but there is a general tendency for women to stop smoking early in pregnancy, but then to start again after they deliver and after they think the baby's safe. So that one of the reasons why these programs have had somewhat modest impact is because they really have the most recalcitrant women who actually enter the program. So they're the ones where it's harder to change their smoking behavior. There's also, as Yerashami suggested many, many years ago, that there's a smoker effect too. The fact that women who smoke tend to be different than women who don't smoke. And so that some of the reason why we don't see necessarily some of the reductions we might expect to see from these interventions may also be, in fact, that there are other risk factors that these women have that increase the risk of low birth weight that's independent of their smoking. Substance use results in terms of interventions, there's very little data out there. There's data to suggest that these interventions are actually quite effective in helping women keep their children. They may be effective in providing more safe environments for children, more safe environments for the women, but there's very little out there that look at actually some kind of pregnancy outcomes. If we look at strategies to improve birth weight specific mortality, the major strategies at the time when we were looking at them, and still at the time really, are what we call regionalization of prenatal care or perinatal care, and new treatments for very low birth weight newborns at the time that we were doing the early estimates. Those treatments have become standard practice at this point. Regionalization of perinatal care is really based on the premise that pregnant women and newborns with a given set of risk factors should receive care from an appropriate level facility, which basically means the very low birth weight babies, moms who have high-risk medical conditions really should be taken care of by people who know how to take care of those high-risk pregnancies and those high-risk newborns. And it really evolved into a coordinated system where there were linkages of services that were provided for both women and the neonate with certain levels of care, and where they could be appropriately provided those care, and particularly where there could be referral or transport of high-risk women or high-risk newborns to an appropriate facility of care. In terms of the effect of regionalization, there was really never any direct effect that actually, or direct evidence that regionalization actually worked. Basically, most of the work was sort of pre-test, post-test. So we knew before regionalization was implemented what mortality rates looked like before and what they look like after. And there was clear evidence that after implementation of regionalization, there was reduction in infant mortality rates and neonatal mortality rates. There was also evidence that when very low birth weight babies were born in tertiary centers, so centers like Hopkins Hospital or centers like the University of Maryland, that those babies had better outcomes. And in fact, there's still considerable evidence that that is still the case with data that have presented more recently. And in particular, those data not only show that there's an effect of sort of the level, that this is a higher level of care that newborns are given, but also that there is a volume effect, so that centers which actually take care of more mothers and more newborns actually have better outcomes. So there's that kind of evidence to suggest that we really should be providing the appropriate level of care to those high-risk moms and newborns. In the early 90s, there was actually a lot of research that suggested that surfactant, which is a substance which helps to mature the lungs of very low birth weight babies, and what it does is it works by increasing the surface tension on the outer area of the lungs so that babies can actually hold the air in their lungs, because if they're born immaturely, they have difficulty breathing. And it showed very clear, those studies showed very clear evidence that use of surfactant reduced infant mortality. There wasn't evidence necessarily that it reduced morbidities, but certainly that it reduced mortality at the time. And then finally, strategies that reduce post-neonatal mortality. Sudden infant death syndrome is one of those strategies that's a focus of the Baltimore City strategy now. And it has been the focus of strategies throughout the country, particularly related to sleep patterns, and also smoking and thinking about reducing post-neonatal mortality. In 1992, the American Academy of Pediatrics actually recommended that babies be placed on their backs to sleep, not on their stomachs, where they had primarily been placed. And this was really based on a number of case-control studies showing an increased odds of sudden infant deaths for babies that were placed on their stomach. There's studies from Europe, from New Zealand, from the United States. And there was evidence after that from Europe that there was a decline in sudden infant death syndrome due to change in sleep patterns. In the U.S., we saw SIDS death go down dramatically in the 90s. And in fact, this was a major focus of many fetal and infant mortality review programs, and in fact, one that we visited, I guess sometime in the late 90s, that was in Lynchburg, Virginia, was specifically focusing on sleep patterns like Baltimore City is now, and actually specifically focusing on sleep patterns among African American families where there seemed to be less of a move to change in sleep patterns. And it's very consistent with the work that Baltimore City is doing now in trying to reduce SIDS and trying to reduce sleep-related deaths. Now, there's evidence in terms of SIDS and smoking that actually maternal smoking is a risk factor for SIDS. But in fact, there doesn't seem to be evidence that, in fact, postpartum exposure to smoking is related to SIDS, which is very interesting, and Meredith has been very helpful in providing that evidence more recently. So what we did when we did our earlier estimates, we then went ahead and looked at how much each one of these particular interventions might reduce infant mortality if they changed a particular amount. And we actually were pretty generous in what we expected would be the changes. And what we basically found was that the interventions that reduced high-risk pregnancies might result in some reduction in infant deaths, but not a large amount. And one of the reasons that's the case is because you have to reduce the high-risk pregnancy first, and then you need to alter the birth outcome. And if the pathway through altering the birth outcome is also through low birth weight or preterm birth, you have to reduce low birth weight before then you alter infant mortality. So we're a few distal steps removed. So those more distal factors had less of an impact on reducing infant mortality. The more proximal ones that actually affected mortality directly, such as regionalization, such as surfactant therapy, and such as post-neonatal mortality, directly affected infant mortality, and they were proximal and therefore had a greater impact. So what we did was we actually, and I'm going to show you the figures, we actually basically showed that, first of all, no matter what we did, what we already knew and the known interventions, and being quite aggressive in changing those interventions, we were not going to get that 50% reduction that President Bush had said we were going to get. But basically what we did was we did sort of independent effects. So we said, okay, if we assume that these interventions are unrelated, then what's sort of the independent effect that we're going to have? We made that estimate, but then we also said, okay, let's see what happens if it's cumulative. So if we go first to decrease high-risk pregnancies, then to decrease low birth weight or preterm birth, then to decrease birth weight-specific mortality, what kind of estimate would we get? And I think what's really important here is, again, this figure shows that the much more proximal interventions are going to have a greater impact on infant mortality. And they're going to have an impact on those particularly high-risk women and high-risk babies. So what are we doing currently? So Meredith has been in the process of starting a literature review to actually look at the 11 high-impact service areas and their potential impact on infant mortality. And what's been interesting about this look has been that a lot of what we knew back in the early 1990s is pretty much what we know now. There's not a lot new here, unfortunately. But that said, we also have learned that there are some pathways through which these high-impact service areas may affect infant mortality, so that we need to think a little bit more, I guess, intermediate outcome related than necessarily focusing specifically on low birth weight or preterm birth. So what we basically have done is Meredith has actually done some work so far in looking at those outcomes where we actually can look at either infant mortality or we can look at low birth weight. And there is some information about smoking that has been updated. There's actually a meta-analysis that's been done of randomized control trials that we actually have found that suggests that those interventions do have some impact on infant mortality. We haven't done these re-estimates yet. We actually are going to be hoping to partner with some folks at the Maternal and Child Health Bureau to access the national data to be able to do these estimates. And the estimates that we did initially were done in the 13 Healthy Start communities that were funded, urban areas that were funded back in the early 1990s, and we plan to do the estimates on the same urban areas that we did before. We have nutrition estimates from WIC, and there's some, at least one or two good studies that have been done on WIC. Alcohol and drugs, there's been only one randomized controlled trial that we could find. I'm a little suspect about the results, so we're trying to find some more. Home visiting. Home visiting is one of those really tricky areas, because if you actually look at low birth weight or preterm birth, home visiting doesn't have much an impact on low birth weight or preterm birth. It's really after the baby that's born when home visiting has most of the impact. There was one randomized controlled trial, however, that has been done looking at women who were at high need for social support and providing services only to those women who are at high need, and in fact, which did show an impact on birth weight, actually, on that one it was birth weight. Many of the other studies really just assumed, just because women were low income, that they were going to need social support. So we're somewhat encouraged that we may be able to find some impact of home visiting, perhaps on post-neonatal mortality or some of the intermediate pathways, but we certainly don't have evidence, except for this one study that targeted high-risk women, that in fact it does improve low birth weight. Preconception care. This is the real dilemma. This is where we are today, where many of our eggs are in that basket right now. Real belief that preconception care and primary care, and proven in women's health status, will improve pregnancy outcomes. Unfortunately, there are not data available. There's some data that are starting to be reported about women and risk behaviors and interventions to improve risky behaviors. But there's really no data that actually link preconception care, primary care, with low birth weight or with infant mortality. So that's an area where actually we're in need of a lot of studies. One of the things, though, that Meredith has been very helpful about is actually pinpointing the pathways through which some of these high-impact areas may affect maternal health and the maternal environment. And basically, she's found studies that suggest that home visiting actually may reduce pregnancy-induced hypertension, and that it also may increase interpregnancy intervals, so that basically increasing birth spacing. Domestic violence interventions have been shown to be related to adoption of mothers of safety behaviors, as well as decreased severity of abuse by the perpetrator. The drug and alcohol interventions, particularly with regard to postpartum effects, have shown that postpartum health environment is actually improved, particularly with if we were to reduce marijuana smoking by parents, this particular fathers. Preconception care, maternal adoption, health behaviors, I already talked a little bit about that, including that there is a lot of evidence showing support for folic acid supplementation, and also some support for adequate physical activity prenatally, increasing adequate prenatal physical activity via activity prior to pregnancy, and then mental health interventions that assistance with resolution of maternal psychosocial risk factors during pregnancy, and that is an important pathway through which we might improve pregnancy outcomes as well. And there's a reference list which Meredith has provided as well. So, thanks.
Audience here, and also from those folks on the web. And again, that email address is maphtc@jhsph.edu. And please, when you ask your question, if you would address it to one of our speakers.
Hi, my name is Kun-san Lee, and actually I'm an MPH student here.
Can you speak a little louder?
I'm an MPH student here attending this session, and I was very impressed by some of the factors that you highlighted, especially like the level of like various interventions, and like how like some of the interventions some of the interventions are not really well focused on. And another thing was actually high level of the low level of accessibility to some kind of like prenatal care and education. And I was wondering if some kind of like cost barrier or cost factor, if like there can be some kind of like prenatal care fund or some kind of like those sort for low-income family to provide some kind of like government funding to reduce that kind of cost barrier. Have you thought of like any of those reduction methodologies?
Yeah, I actually, maybe the point wasn't clear. The issue was not access to care that those individuals had. In fact, what we were doing was estimating if we did improve care, what would happen to infant mortality rates. It's really more the potential impact of that intervention on the outcome. So there are actually a number of programs that are available for low-income women, and I guess maybe Rebecca might want to answer that, because there are several programs in the city, and one of them for which I'm particularly familiar is Healthy Start, which targets low-income area both in East and West Baltimore.
I mean, there are programs, and prenatal care and immediate postpartum care is available for free for women. So the issue is less the cost issue than the complexity with which it takes for women to actually get involved in a managed care organization. So these managed care organizations exist, but the hoops you have to jump through to actually get to a point where you can get the services is what is a barrier right now. And then there are a lot of women, for example, immigrant populations in the city who don't want to go into that kind of system for fear of, whatever, even though they're offered these free services as well. So there's that issue. But it's really the lateness with which women are getting into prenatal care because of the barriers with the complexity of the insurance system itself. So it's not so much that the services don't exist, although one could say about other services what you aren't insured for when you're not pregnant or you don't have your immediate postpartum period. There's a problem with access to care, but for infants and pregnant women, the care, the services are free. The problem is that getting into those services can be complex. And if you don't come through Baltimore Healthcare Access, which is the existing program in the city that gives you entry, and it takes 10 days, I think, to turn around your insurance. If you go through the Department of Social Services, it's a much longer time period for women because they have all kinds of other cash assistance programs that they need to that they're also eligible for, that they also need to sign up for. So there's a number of barriers that are systematic, that are less an issue of a cost when it comes to prenatal care specifically. But there are 8 home visiting programs in the city for low-income women that exist, but there's still at least 2,500 women in the city who don't access those programs, either because they're high risk or because they can't, because they haven't gotten into the system officially. But thanks for the question.
Joy, you had a question?
Is Baltimore City a part of the National Children's Study? Because they have about 15 to 20 preconception measures there, and it's coming up in 2011.
Actually, Baltimore City is not. Baltimore County is part of it. There's 2 sites in Baltimore County. I think there's also one in Montgomery County, and there's one up in Wilmington, Delaware, Newark. Yeah, but not Baltimore City. And that was just based on the random sampling. Baltimore City did not get selected. Yeah.
Yes, my name is Jennifer Wright. I'm a visiting student here from Michigan State University, however, interning within the Department of Environmental Health Science. And I just have a follow-up question to that. You were talking about some of the barriers as far as the navigation through the system. Will there be any improvements that will be made in order to facilitate that navigation through some of the barriers that you mentioned?
I think it's a great question, and if you want to come work with us for a while. There are some strategies. We're thinking about it. For one thing, even now, before this strategy is officially kicked off, we're working with the Department of Social Services to look at, are there ways in which they could, at least for pregnant women who come into their system, just quickly get them into a rapid access system so that they get their medical insurance before they get these other. So there are small things that we can do. I mean, there's obviously bigger things that, but this is an area that we're really studying right now. But for example, at the very least, going into the points of it, like going to the Department of Public Safety and working with people in the Department of Public Safety who deal with women in transitional settings, or any kind of area where we think we can identify high-risk women in the city. We're trying to go and at least do in-service trainings for staff, get them aware of Baltimore healthcare access as a service that exists for women in the city. So there are a lot of educational things we can do that don't have to get into the deep systematic problems. But because this is way high on the health commissioner's agenda and on the mayor's agenda, I think ultimately we're going to be starting to address some of the deeper systematic issues. But we are, as I can say, I can make a plug now, since there are a lot of smart people in this room, that we're always looking for people who can help us think through, analyze data, help us think through some of these different issues. So, yeah.
David had a question.
Donna, I would say that maybe one approach that may ultimately prove a bit more productive is to unwrap low birth weight. Think of it more as a crude indicator and begin to think of the multiple streams that result in low birth weight, both preconceptually, early on in pregnancy, so that we can begin to try to track through which of the problems we may be addressing and which ones we aren't, so that refining it to fetal growth restriction is one way to do it. But even beyond that, there are ways to begin to isolate specific causes, which may be genetic, it may be nutritional, it may be behavioral, it may be drugs, illicit or illicit, so that we can begin to think of this in a more discrete fashion. Most of our indicators and our approach are somewhat global. You parse them in the appropriate way, preconception and so on. But we still approach it globally. We don't approach it in terms of trying at least to understand the problem and then to develop the interventions appropriate to that.
Yeah, I think you're right. And I think that just to make a comment and then see what else you have to say about this, but I think by trying to look at the dimensions, like looking at nutrition, looking at smoking, looking at some of the interventions that may affect, I think, fetal growth. You're right. I think the problem we have, David, is that once we start splitting that and we're looking at a population basis, we're starting talking about small numbers. So I think you're right about we need to think about it in terms of the pathways. I think when we get to the numbers, one of the reasons we added preterm births, because you will remember when we did these estimates years ago, we didn't do preterm birth. We didn't do preterm birth because we were pretty suspect about the quality of the gestational age data at that point. I think we're not as suspect about those data anymore, which is one of the reasons why we're updating it and wanting to put preterm birth into the mix. But I think we can be cognizant of the pathways, but I think once we start to split them into smaller pieces, we have a lot more trouble estimating what's going to happen on a population basis. And remember, we're not talking about precision here. We're really talking more about sort of getting a best estimate or a guesstimate of what might happen.
If I may, just...
David, could you speak up, please, and could you all speak up? Some of our web visitors aren't
I'm
here.
sorry. The reason I raise it is with respect to the intervention strategies,
Right.
in terms of how to emphasize this and how to move through the pregnancy in terms of counseling, both preconceptually and conceptually. I'm also reminded of the fact that some of the interventions may be paying off, but we're reducing spontaneous abortion and early fetal loss, which we know is an old problem.
Yes, absolutely.
That has haunted
Right.
This particular...
The failures of our success.
The failures of our success. Another indicator would be looking at congenital anomalies, because really this is the major cause of infant mortality currently in the U.S. And it's a sentinel to what's occurring at a particular point in the pregnancy. So the reason I'm raising it is not because I have any solutions, but to begin to think through strategies that will help us begin to parse the event and then develop the intervention that may be productive at particular points in time, rather than investing in some comprehensive set of discussions. We can bring the family and the woman and the pregnancy point by point in a more productive, efficient manner.
Absolutely agree.
Go ahead.
I'm Sana from Donna's department. From my own research, I found whether the father is around makes a huge difference in birth outcomes and infant mortality. So I wonder if there's any intervention that target father's involvement. And I also want to ask Donna if there's any research evidence showing such interventions work.
Well, to your first question, the role of men is going to play a major part. The target is ages 11 to 49 men and women. So school-age boys, there'll be specific interventions for each age group. Those interventions, however, haven't specifically been identified yet because the communications vendor and the community programs are going to be identifying. But I would be very eager to hear Donna's response because we've engaged, I mean, interestingly enough, there aren't that many groups very focused on men, although you see some good, major billboards around the city. In fact, there's one major billboard that Stephanie and I saw yesterday where the father's lying down with his baby, except that the baby's asleep on the father's stomach and on the baby's stomach. So we were like, oh, great ad, engage the man and have the baby sleep on the stomach. So some of these ads may need to be rethought through, but we definitely need to be focused on that. And in fact, when we do our education and in-services in the detention centers, we definitely go to the men's area and the women's area, and that can be very interesting, but yeah.
I don't know. Meredith, do you know?
Well, I do know, I have limited knowledge that for breastfeeding, since that is one of the high infect areas, there is research that has indicated that involving men in prenatally and postpartum and breastfeeding education does lead to higher uptake of initiation of breastfeeding for women.
So those of you who are listening on the webcast, Meredith just said that some work that she has found indicates that involving fathers with women who are thinking about breastfeeding increases the uptake of breastfeeding. Yeah, Amy.
I'm curious about the home visits. You call it an intervention. I think of it as an access issue. Is there a dose response? Is there evidence of dose response to home visitation? Why just one visit? Why not multiple visits for the high risk?
Yeah, and I think most of what I was talking about in terms of the programs that have done home visiting have been multiple visits, not just one.
I think I heard Rebecca.
Well, yeah, and I should be really clear. Home visiting will be available for high-risk women by nurses on a monthly, possibly even higher, even more frequent basis. The only point I was making is that we want to do at least one home visit to all the women in the neighborhood, because what we're finding is that a lot of the women that we have in our home visiting programs are women that are already in the system, so they may not even be women who are having the poor birth outcomes. And if you ask the programs, if you look at the data from each of the home visiting programs, they're very good. You think, well, what on earth is going on in Baltimore since these programs are doing so well? And the point is possibly one explanation is that the women that are actually in these programs may not necessarily be the women that actually need the services. So the point of that is only because it's so hard to, I know that Healthy Start does a lot of door-to-door canvassing. There are all kinds of ways, but I don't know how, it's almost like finding a needle in the haystack sometimes with these women, whereas most women, it's not like in the developing world, most women are not delivering at home, they're delivering in a hospital, so once you find them in the hospital, it's easier to then have a home visit, and you haven't prevented the poor birth outcome of that particular pregnancy necessarily, but you can do a lot with sleep education, breastfeeding, and then, family planning services and that sort of thing. But those that would need the services would then go on to have services either from a paraprofessional or professional, depending on their needs.
I'd like to take a question from our web-based audience, and here's a question, and I think this is for you, Rebecca. Does your number of SIDS deaths include deaths from unsafe sleep, not just SIDS, or just true SIDS?
The numbers that I showed are that include unsafe sleeping environment confirmed and unsafe sleeping environment not confirmed, and they include SIDS, SUDI, asphyxia, and then unspecified and accidental suffocation and strangulation. So we're considering all of those possible sleep-related. Stephanie, I don't know if you want to say anything further on that, but
Those are overwhelmingly sleep-related
Right.
deaths. They are coded as sleep because that's the best we have as far as coding. But we're finding that over 90% of them, there was an unsafe sleeping environment involved.
Okay. One of our colleagues in Carlisle, Pennsylvania, actually wanted to share with us a website for their program called the Nurse Family Partnership Organization. And they have a program there where they enroll women at 28 weeks of gestation, and they do multiple home visiting, and they really have shown, they've had rigorous clinical trials that have shown improved infant birth weights, less prematurity, less child neglect abuse, less incarceration, higher IQ scores. And this is based on the work of David Olds, who did work here at Baltimore City in the 1970s. And the email of that, the URL is nursefamilypartnership.org. I wanted to make a point, if I could, speaking now as myself, to David's point and Donna's point, and this is not so much related really to the behaviors involved in low birth weight, but it's something we've been thinking a lot about sort of in the broader preventive medicine community, because we all look at typical epi risk factors. You know, we think of age, income, socioeconomic, whatever, but I think it's possible that we're actually losing a lot of information because we really keep using those risk factors. And if you look at some of our marketing colleagues, people who do marketing research on things that are not health related, they break out human behaviors in a very, very different paradigm. And they, for instance, there's a group that grew out of Stanford that has something called VALS, and it's value, attitudes, lifestyles, and they find that actually it's much less important whether you have a college education and you make $100,000, and it's much more important, for instance, to stratify people by the kind of car people buy in that income. And again, that's only one tiny little example, but it turns out that it's not as important how much you make, but how you choose to use your income. And in the VALS schema, they actually have, I think, 20 different categories where they break down the American public in terms of values, attitudes, and lifestyles. And I think that it's relevant here in terms of, again, thinking about people getting away from our typical epi measures, which are, you know, age, gender, socioeconomic.
other questions, Jeff?
Yeah.
Actually, I just wanted to maybe comment on your comment. Because actually sometimes you can see some immigrant populations with very limited economic status, but still, I mean, like, I have seen, actually it is my personal experience, I have seen some people who came to the United States with like, you know, about like $500 or $600, but they have been very, the way of using their limited resource might be varied between like people and according to their value. So I think that might be really important point. And another thing is, in terms of, now I realize that it is not the problem of monetary accessibility, but the problem of all this issue of navigating through the system and some kind of systematic barrier. And it seems Healthy Start is really doing well for those babies who are already born. But I was wondering if there can be some kind of idea about starting some kind of like case management at the times of like, you know, conception, or at the time when the mothers know that they are pregnant.
Yeah, Healthy Start, actually there are 8 home visiting programs in the city, and they all start with when the mother is pregnant. So they begin the minute that either you find the mother in the neighborhood and find she's pregnant, or through an obstetrician who makes a referral to the home visiting program saying that a high-risk mom who's pregnant needs services from one of those 8 programs. So the home visiting programs do serve pregnant women, and then it varies how long they stay with the women.
But some kind of like case management to help those mothers to navigate through the system.
And that's the role of Baltimore Healthcare Access. That's exactly what they're supposed to do, that agency in Baltimore City, is to help women navigate through the system. The problem is they don't necessarily find all those women, or early enough, because once a woman's pregnant, you still, even though Baltimore Healthcare Access can get them in their initial insurance, you still have to select an MCO. I could go on, and I mean, the packet that I was given on the MCOs and how to get in is literally this thick, and it's but.
And I think perhaps you're also referring to some of the more ad hoc or community-based community health worker program, where it's not just about getting the insurance card, but it's about helping the women get transportation to get to their appointment, or to provide childcare for their other children, or to be able to find a pharmacy in their neighborhood. Certainly here in East Baltimore, although there are a lot of medications now that are $4 medications, there aren't any pharmacies that offer them. So I think those are
And that's exactly what these programs are aiming to do. I mean, they're providing transportation, but when the woman is already in her third trimester and she's coming into the program, you can still do those things, and you'll provide those services through the age of 1, 2, or 3, depending on the program. But yeah.
We have one more question from our colleague in Washington, and his comment is that he's concerned about what do you do with pregnant women or new moms after you've screened them and you found depression. And his experience has been that there haven't been enough services, not for substance abuse, but just mental health care for pregnant women and moms. Could either of you address that, please?
I mean, it's a huge issue in Baltimore, and one of the reasons that Baltimore Mental Health Systems has been called to action is because, there's a couple, there's many factors. One is the stigma around mental health services at all is one of the barriers. So even if there were services, there's a lot of reservations or barriers that women have or men in seeking those services in the city. But the second is the services even being available or anybody being able to pay for those services. So it's a very relevant issue, and it's something that we're tackling right on. And I see that Darius Tandon left, unfortunately, but he would probably be a great person to comment on this as well. But Donna, I don't know if you have.
Yeah, no, I think it's a major problem, and I think it's a major problem because we often don't coordinate the actual depression screening with then referral. I actually have been working with a program in Delaware where they actually do screen women with the Center for Epidemiological Studies depression scale on their first prenatal visit, and they actually do refer women to mental health services. So if you actually, whoever it is, can send me an email, and I can provide you with the contact of the director of that program there, and she might actually be able to help you. But that's actually a program where that was developed as part of the program, and I don't know whether the person who's asking the question does this sort of independently and then has it trouble finding referrals, or whether it's actually part of or resources, or it's actually part of a program.
But I should clarify that all of these programs also, they do screening and they refer.
And they refer.
But
Yeah.
the problem is that people may not take those referrals and go, or the referrals may be into situations that are complex to try to
Right,
navigate.
and there is a lot of stigma associated with mental health in many of the urban communities. Luke, you had a question?
Well, I have heard some discussion about the potential benefit of group prenatal counseling services or approaches that form support groups among women who are at similar stages in their pregnancy. Is that, where's the evidence, or what's the state of thinking about that type of approach?
Well, there's a program that's been introduced by nurse midwives that's called Centering Pregnancy, which I think is sort of the concept that you're talking about. There's a lot of discussion about that as a model, because it really does bring together women who are pregnant and actually can provide a support group for each other. I don't think there's a lot of discussion about the model. There's a lot of discussion about why it works. And there's certainly evidence to suggest that nurse midwifery care for low-income women is some of the best care that's actually provided, as long as they aren't high medical risk, or even when combined with women who have high medical risk. Using an obstetrician and nurse midwife is actually quite good care. I don't think there's a lot of scientific evidence, though, to support it. I think the notion is quite intriguing, and I think it is very supportive of, the nurse midwifery model and that whole approach to care. But we don't have really very good data on it. Now, it's been a little while since I've looked at that data. Have you actually looked at centering pregnancy?
I haven't, but I just wanted to let you know that centering pregnancy is a priority for March of Dimes funding right now. And so any RFPs that come in for centering pregnancy have priority funding. And so I think March of Dimes is probably going to be undertaking some research.
Well, we just were told that centering pregnancy is a March of Dimes high priority right now, and so hopefully there will be more looking at that. And certainly, in terms of chronic diseases, not in the pregnant population, there's very good evidence that these programs work for diabetes management, for weight management, extremely good evidence. The problem is, and I don't know if this would be a problem in this population, is no one can find funding for them because all the funding is always set up for on a fee-for-service direct delivery. I think we are just about out of time, and so I'd like to ask everyone please here to fill out an evaluation and turn it in to us. And those of you online, please to fax it in. And I'd like to thank our speakers very much. And since this program is just beginning, I'm positive we'll be doing this again, perhaps one mid-course and one when we're finished. Thank you all.
And thank you all for coming.